Okay, everyone present?
Yep, JonaChan present here.
Yep, Kino's here.
Hey, let's start the Nugget Rounds.
Our new rotators. Nugget Rounds is our weekly chat where we take turns sharing some nuggets of knowledge we've picked up. If you have a nugget to share, feel free to post it down below.
So guys, anong na-gets nyo this week?
I think ako, I'll share mine first. I think sa akin kasi more on sa trophoblastic diseases because I got assigned to a tropho case. And then, yun, di ba the typical manifestation that we see in tropho patients? The symptoms, di ba, ang symptoms ng tropho cases is para siyang pregnant talaga. Like, you mistake it as a pregnancy pag sa tropho. Like, vaginal bleeding, tapos malaki yung abdomen, and then high beta HCG. So, same din, typical presentation with the pero yung kanya kasi it started 2014 and then up until now talagang meron pa rin. Like the highest beta HCG titer that 100,000 beta HCG, so talagang malaki talaga siya. And then talagang malaki when you saw when I saw the patient din talaga, malaki din talaga yung ano niya, yung belly niya, and then yung pinalpate ko, yun, matigas. Pero I think it's another ano na entity or another kasi, upon assessment it was myoma uteri daw. Pero yun nga, okay, going to the main discussion is which is the tropho nga, tropho case. Reiterate siya sa'min talaga ng residents na maka-encounter ka ng patients na who miss their menses, na akala nila pregnant sila. It's still better that you suggest na magpa-OB sila para just to make sure na hindi siya tropho. Kasi 'di ba, trophoblastic diseases is common sa mga Philippines, sa ating mga Southeast Asians. It's more prevalent sa mga Southeast Asian compared sa mga Caucasians. So I think that's the main takeaway I had for this week. Kasi minsan we always assume na once na may signs of pregnancy, we always assume na preggy siya, and then hindi na natin hindi na agad din napapansin. At saka 'di ba minsan hindi naman lahat ng Pilipino may funds, may resources for OB checkup. So yun, I think that's
Tina, actually just have a question. For cases of trophoblastic diseases, like what age group were you familiar with what you know so far?
basing sa lectures, 'di ba sinasabi nila yung J-curve. So, yun yung mga teenagers and minsan yung mga reproductive age women who are 40 years of age or older. So, yung talagang mga mga bata talaga, and then mga nasa at the end of the spectrum na. So, dun talaga sila at risk the for for HMOL. Pero yung comparing to to some patients, may iba around mga 28, mga gano'n. So, 'di ba medyo nasa midline siya. So, siyempre kailangan mo din i-assess din kung ano ba yung other risk factors niya. So, siguro hindi yung age niya yung risk factor for that. So, maybe sa ano siya, racial I think, since 'di ba high higher risk yung mga Southeast Asians, tayong mga Filipinos. Pero isa lang naman yun, eh. So, mahirap din talagang alamin kung talagang at risk din yung family. Pero wala naman sa family nilang may mga gano'n, wala ding cancer. So, siguro depende din talaga sa patients, variable talaga.
Yeah, that's an interesting thing, guys. Especially since parang hirap control when the risk factor is just being yourself and
Yeah.
being Filipino.
Oo, totoo. Sobrang na-influence din talaga din ng pandemic yung medyo nawawala na rin ako sa main topic. So, napansin ko lang din na talagang sobrang laki din talaga ng effect ng pandemic sa mga cancer patients.
There's a lot of people na neglect, 'di ba? Yung cases nila since
Hmm. And then the patients din, natatakot din silang pumunta sa hospital kasi 'di ba the risk of maybe getting infected with COVID, lalo na 'pag may mga patients din na may experience sila, nag-positive sila, siyempre matatakot silang pumunta sa mga specific hospitals na who only offers the treatment na available for their specific, diseases, gano'n. So, mahirap talaga siya.
agree.
Yeah, that's why I like it na I hear people a lot of those patients, it's hard to say lost to follow up when really they were lost due to the pandemic. Said all of the access issues and transport, and everybody naman I think has that baseline anxiety going out nowadays. Europe.
Yeah.
Okay.
So Kino, what's your learnings for this week?
Nuggets gonna streak fine because just I had a quick review suddenly of the route of the CSF. So para the good refresher for all of us, yung route ng CSF from the choroid plexus to the lateral ventricle to the foramen of Monroe to the third ventricle to the aqueduct of Sylvius, the fourth ventricle to the lateral foramina or luschka, so lateral luschka, and medial foramen or Magendi. Tapos yung subarachnoid space, arachnoid granulations, na from there will be help move to the dura sinus and the venous drainage.
Mm.
And interesting na, I've always wondered, how do you get from blood to CSF? And it's actually filtration of plasma through epithelial cells na active transport and an osmotic gradient. And with the brain stuff also, since we were talking about that this week, it was interesting na for a lot of masses pala in the brain, especially if on imaging you see it's a mostly cystic mass, you can do a smaller opening just so you can drain them instead of having to cut it out and everything,
Mm.
as compared to solid masses where you'll have to plan your route for both opening the skull and how to pass that mass through
Yeah.
it. But I think the most important thing of my nuggets this week was a discussion on confidentiality. So it was part of one of the discussions about what really are the legalities of confidentiality, especially here in the Philippines. And based on one of the Mental Health Act, or RA 11036, there's parang five categorizations. There's five ways to to allow someone to talk about your confidentiality. And it's if you're required by law, if the service user, in this case the patient, has expressed consent to share it, if there's a life-threatening emergency to the self, others, or society, if the service user is a minor and might be a victim of child abuse, or if it needs to be part of a criminal case, civil or administrative case against the mental health professionals. So we have this like nice guideline talaga of when we can talk about someone's case with regards to confidentiality, since in real life you have to take into account that we're dealing with real patients and we're dealing with them in ways that there are lives outside of what we see of them, as much as we have lives outside of the
Yeah.
hospital.
True. Actually,
That's a very good point, no, Kino.
naisip ko rin 'yan kasi 'di ba we as Filipinos mahilig tayong gossip-gossip. Minsan, if nandun kunyari, you're the type of Filipino na ganyan and then physician ka, na mahirap siya. Minsan talaga may ibang, tao na nasasabi, nasa-slip talaga yung mga infos.
Yeah, that's very true, especially when we compare our culture compared to say the US. In the US, you're not even allowed to tell the person's family. Pero here kasi, like, diba, you're in
The guidelines, diba?
yeah, you're in
Like
the wards.
really,
If someone's standing there, carry lang kasi they're the bantay, that they're family. So they can hear all
yeah,
about it. Kahit hindi blood relation friends mo. I'm sure when we're sick, we've talked to someone about it or
Hmm.
ay nakwento na ganito.
yeah,
So while it's a privacy issue in the strict or if you go to the very like US sense, pero our culture still sort of mediates that and affects how we approach that kind of confidentiality discussion. So it's an interesting thing to think about, especially here in the Philippines.
yeah. That's
True. Even like when discussing it with your coworkers, it's
Yeah.
very common talaga na you discuss it with your coworkers. So ang hirap din talaga magtanggal din ng
especially when
info.
you have a very stressful week and you just want to unload your feelings to other people. It's very hard to filter that out, especially with your coworkers, since you feel like, oh, you're your coworkers anyway.
And I feel like that was a problem now with this pandemic, since people can't go out and socialize in that way
Yeah.
anymore. So people can't de-stress
Oh,
after a long day in
Hmm,
the hospital or
yeah.
whatever.
Kind of miss, yun yung
yeah.
na-miss natin with the pandemic, that a lot of us really can't bond with each other, and di ba, no man's an island. So that's one of the struggles that this pandemic really brought to us.
Yeah, like when was the last time you were able to go to Sandgip at 11 p.m. and just run into everybody?
Tagal na.
Ano eh, events are close like after mga actually early in the evening pa lang eh, 'di ba?
Yeah, like 8 p.m.
O minsan as early as that.
Mm.
I'm sad ka, the Bakdo nearest me closes pala at night. So
Yeah.
if you're
Yeah.
hungry, you have to have it delivered talaga.
So, wala talaga nagde-deliver 24 hours, pero meron 'di ba? Sa
Yeah,
Oh, they deliver 24 hours. It's just that it comes from the other store,
may
like
mga different
across
stores
town.
that work 24/7. Pero may mga iba, most stores don't open 24/7 anymore.
mm.
Yeah, sad.
Speaking of fast food, I'm going to be talking about cholelithiasis and so
Oh.
stuff about fatty food.
What?
Wow.
Para segue, no?
Tama,
Oo,
tama.
tama,
Tamang segue,
tama.
tamang segue.
Yeah. So
Galing, ah.
basically, this is like a common thing that people or med students get confused over since they sound very similar. These are the terms cholelithiasis, cholecystitis, choledocholitis, and cholangitis. So those are four very similar terms, and they pertain to pathologies in the biliary tree. Uh, just to recall, no, yung anatomy natin so that we're all on the same page. So remember, like from the liver, it drains, the bile gets drained to the right hepatic duct and the left hepatic duct to form the common hepatic duct. And from the gallbladder, which is our storage of bile, uh, bile gets out through the cystic duct. And then the cystic duct and the common hepatic duct combines to form the common bile duct. And from the common bile duct, the bile flows to the ampulla of Vater, which is to the second portion of the duodenum. Now, just to briefly recall, diba, we have the four. So what are the four? So briefly, cholelithiasis, that just means you have stones in the gallbladder. If it's cholecystitis, this is inflammation of the gallbladder. And if we talk about choledocholitis, diba, choledocho, that's the common bile duct, the stones get lodged into the common bile duct. And finally, if we have cholangitis, this is infection of the common bile duct. So basically, it's choledocholitis, like choledocholitis, but you have an infection. Yung nuggets ko for this week, aside from discussing all of that, would be yung differentiation of the four. So for cholelithiasis, diba, this is just your common gallstones. And you have here biliary colic, usually is a clinical presentation. So ba ito yung pain associated with meals. So like if you have fatty food, but your gallbladder tries to contract, so you feel pain when you have cholelithiasis. So ano siya? It's just happens every so often. Treatment here is to an elective removal of your gallbladder called a cholecystectomy. What happens if it gets inflamed? So this is when you have cholecystitis. So now the pain is more constant compared to yung kanina na more colicky. And a very common thing that's asked to rotators or on multiple choice exams would be the Murphy sign. So yung Murphy sign, this is yung acute pain and inspiratory arrest when you have palpation of the right upper quadrant during inspiration. And this is slightly different from what's known as the sonographic Murphy sign, which is just pain elicited during ultrasound when you probe the right upper quadrant. So sonographic Murphy sign is just pain when you put the ultrasound probe in the right upper quadrant. Whereas Murphy sign, there's inspiratory arrest. So that's something that can get asked when you wheel in a patient to the ultrasound room and the radiologist would ask you questions.
Mhm.
For choledocholitis, again, this is the stone in the common bile duct. Uh, what we do here for diagnosis and treatment is what we call ERCP. Ba? So, for ERCP, saying this is endoscopic retrograde, yung ERCP, it's an acronym and it's quite a mouthful actually to say, but endoscopic retrograde cholangiopancreatography, or you just call it ERCP. Basically, we use it to diagnose if there's a stone dun sa common bile duct, and we can also use it to remove the stone if there's a stone present. That's what you have for this disease entity. As mentioned earlier, so you have if the common bile duct and the biliary tree gets infected, you get cholangitis. So for cholangitis, there's a criteria. Actually, cholangitis and cholecystitis has criteria that some of you guys can are familiar with, or if you're not familiar with, you can just search, which is called the Tokyo Guidelines. Currently, we use the Tokyo Guidelines of 2018. But a common question then asked in the boards or asked in the wards is yung Charcot Triad and the Reynolds Pentad. So, do you guys remember what Charcot Triad is? Meron ba nakakalaan? Well,
Fever,
yeah, fever is one.
Murphy sign,
Okay.
pain. I forgot the last one.
Yung ano, tama naman yun. Though, fever, that's correct. Murphy said more of the right upper quadrant pain. So it's right upper quadrant pain. And the last one is jaundice. Kasi 'di ba?
Jaundice, yeah.
You most likely have a constriction, 'di ba? You have an obstruction rather in the biliary tree. So you'd have jaundice. So that's Charcot's triad: fever, right upper quadrant pain, and jaundice. And finally, if you have a more severe case of cholangitis, you'd also have shock and altered mental status, which constitutes your Reynolds Pentad.
Raynaud's.
Yeah, that's
Yeah.
Reynolds Pentad. So Charcot's triad plus shock and altered mental status, that's Reynolds Pentad. Ang treatment dito is emergent ERCP. So kung kanina sa choledocholitis, that's you're more chill about ERCP. Here it's emergent. So yun yung treatment for that. So to summarize, we have cholelithiasis, which is gallstones in the bladder. If it's more severe, you have cholecystitis, which is inflammation of the bladder, typically caused by the gallstone obstructing the cystic duct or what have you. And then if it gets lodged into the common bile duct, it's more severe, which is your choledocholitis. And the most severe among the four is cholangitis, which is infection of the common bile duct. So that's my nuggets for the week.
So how long do you think do they do the ERCP?
The ERCP. This one, I'm not entirely sure how long nagagawa yung ERCP. Kasi aside from ERCP, usually kapag ano na siya, they also do surgery as well, which is either open or laparoscopic cholecystectomy. Yung ERCP, I'm not sure how long, but it shouldn't be that long. It shouldn't take an hour, I guess. But yung chole, sina chole na surgery, I've assisted in one. Parang this one can be done as fast as like 2 hours. Definitive surgery for these biliary tree pathologies.
Is that lap surgery?
Yung I haven't seen a lap cole before, but I've seen an open cole. Yun medyo mas
Same.
matagal ata, but around 2 hours. Yeah.
Totoo. Nung clerkship ko, nakapag-observe ako ng open lap. Tapos, grabe ang tagal niya. Kasi meron pa siyang IOC. May IOC pa siya.
Yeah.
Tapos like 2 times kaming nag-IOC. Ang tagal, gano'n pala siya katagal.
Oo.
So talagang na-miss na namin yung lunch namin. Like from 9 a.m. kami nag-start, then we ended at around 2 p.m. So ang tagal niya.
Oo. Kasi
Grabe.
Kasi if you're not sure if there's a stone there, diba? You might have to do an intraoperative cholangiogram.
Yeah. Grabe, ang tagal nun. Ang init pa. Actually, ang init pa nung OR. Like, aircon siya, pero kasi when you do assist, 'di ba, sa'yo nakatapat na yung light, ta's nasa specific lang na position ka, so ngalay ka na rin. May time nga na parang parang feeling ko makakatulog na ako.
Oh no, that's super a
Parang
thing.
feeling ko magko-collapse na ako. Parang, oh my gosh, tis na lang talaga for the patient para matapos na.
But I guess some people appreciate operations more, I guess. Kasi, for example, me, I thought I wouldn't appreciate assisting in surgery, but I actually really enjoy it because I really see the relevance of anatomy in surgery. Whereas before, I really thought anatomy is a very dull subject for me since it's just memorization. But here we can see na, useful pala yung mga inaral ko dati.
Totoo.
So true. I think it's like, depending how active your role is, because there's sometimes, diba, you can't see the field na and you're just retracting. So that one na parang you get a bit boring and you're just standing there. Pero when you can lean in, you can actively appreciate everything and it's not just a bundle of blood and misshapen and tissue and whatnot. And you're like, now I get it.
Yeah. Pero maganda yung pag sa mga open lap. Kita mo din talaga. Pero nga, di ba, kailangan talaga siyang i-dig in kasi medyo especially kapag sa mga obese patients, mahirap din siyang hanapin sa mga those type of patients. Like talagang si mismong main surgeon na ang ano talagang makakakita kasi ihahawi pa niya talaga kahit naka-retract na siya.
Actually, this really gets into training of surgeons, no? I mean, that's why their training is very long because a lot of it really comes down to technique.
Mm.
Yeah, it's really something that you have to practice. Kaya gets na parang in the pandemic where you hear that their competencies are based on how many ORs you
Yeah.
did and how did you do that one. Because it makes sense that really is their practice, to be able to do something
Yeah.
and be able to do it well.
Yeah.
So, what a fun discussion we had this week. Come on, very, very varied. I love it.
Mm.
Does anyone have any last bites they want to share?
No, I guess we're good since gusto rin natin na matakam yung listeners natin for the next few episodes.
Yes.
Exciting. Okay, so with that,
So that's our show, guys.
Stay hungry for nuggets and see you next
see
week.
you next week.